Much. Okay, our next talk is on feeding avoidance and RASopathies, and this will be presented by Keir Shiels and Angharad Roberts from Great Ormond Street Hospital in London.
Hello, everybody. I'm obviously not two people. Ang Roberts is sitting over there, but because I talk for far too long, it's been decided that I should do the talk, because otherwise I will rather rudely not let her get a word in edgeways. Oh, that's very loud. Thank you very much for staying. It's been a fantastic conference so far. Thank you in particular to our first talk, which I thought was incredibly important for us all to hear and listen to. We've heard about neuromodulation, we've heard about organoids, we've heard about metabolic profiling. I've come all the way from the UK actually to talk to you about a magic lemon. More of that later. Now, I've got to try and work out how this thing works. Now, is it that one? That one, green button, excellent. So I am a paediatric attending consultant at Great Ormond Street Hospital in London. And we run a RASopathy clinic, which was originally designed 3.5 years ago to have a capacity of 75 patients. We just admitted our 200th last week. So it's slightly burgeoning at the seams, but ever increasing. We accept patients from all over the UK, and we've got a couple from the Republic of Ireland. And our role really is to try and support children's local physicians and local specialists to better manage children with RASopathies. Now, the first consultation that you get is with a specialist nurse and myself, which is an hour-long consultation to go through a variety of different areas of the diagnosis. And then we follow up every 3 years in a multi-specialty clinic that includes cardiology, endocrinology, genetics, general pediatrics, and nursing. And the idea is to sort of split childhood up into 3-year chunks and give a sort of instruction manual, as it were, of what to expect over the coming few years, so that local teams can better support children with RASopathies. This is part of our faculty. Ang is our geneticist. We've got cardiologists, endocrinologists. Elaine is our neurodevelopmental specialist. And we've got a research team as well. Matil has got a poster outside, which is very good. And I'll be referring to her data in this talk so that she can put on her CV that her data's been presented twice. These are all of the different faculties of RASopathy management that we cover in the clinic, from the medical background, growth, etc. I won't read those out. You're more than fully capable of doing that yourself, even without access to coffee at the moment. But what I want to talk to you about really is the stuff that is managed badly. I want to sort of lance the boil. We have done some research, this is Matil's work, to look at what the priorities are for families, because the literature is full of stuff about genotypes and stuff about cardiology. But really, the stuff that matters to families day to day is stuff that affects them day to day. And we heard very powerfully in the first talk about feeding difficulties being a significant problem. And what you can see there in the data is that about 30% rate leg pains or feeding difficulties in their top priority. Now, if you actually filter out the people who don't have leg pains and don't have feeding difficulties, they're actually in their top 3. Okay, so it's quite a significant thing, and it's got a similar prevalence to inherited cardiac abnormality, feeding difficulty. It's got a similar prevalence to leg pain, but it doesn't occur in the literature as much as we've already heard. More scandalously, what we see is that roughly a third of families describe their local pediatricians, local physicians as being actively dismissive of issues regarding leg pains or feeding difficulty. And I was speaking to a family just yesterday whose pediatrician described their vomiting as a laundry problem because their child was growing well. And as we heard at the very start of this session, it's an issue that really, really affects children and families badly throughout childhood. Now, there are lots of different things that can affect feeding. we see at birth, we can have cardiac abnormalities, chylothoraxes. We see that in the first 2 years at least, vomiting is an incredibly significant problem, sometimes that self-resolves, sometimes that never goes away. The ones who vomit terribly are much higher risk of developing oral aversion, which is another form of feeding resistance. And then from the ages of sort of 4 onwards, some of those more stereotypically autistic behaviors, for example, of sensory sensitivities, visual, textural aversion, start coming into play. And all the way through that period, you've got what I sort of term a dysregulated appetite. A lot of children with Noonan syndrome are much more grazing. They sort of consider eating a bit like I consider doing the ironing. It's something that you have to get through, but it's not pleasant in the way that I love gorging on a sandwich. Other children with Noonan syndrome tend to have more of a grazing appetite, picking and chewing and not really enjoying meals as much. One of the roles of the clinic is to sort of unpick a little bit about what might be interfering with feeding. And so what we need to make sure is that there's no diagnostic overshadowing of people assuming that the vomiting is caused by simple reflux or caused by milk allergy. We see loads of children who are put on a variety of different milks in the attempt to try and improve their vomiting, which which doesn't usually work. Some of our children actually do quite well on a blended diet, unusually. I'm not sure what the underlying reason for that is, but getting them onto a blended diet has helped quite a few. With the oral aversion, there's always a discussion about the necessity for various different feeding adjuncts, nasogastric tubes, pegs, etc. One of the important things is to try and make sure that feeding and food is actually an enjoyable experience. And I'll come on in a little bit when I talk about feed aversion about that. And so making sure that enough is tolerated and that food is not always associated with vomiting really tries to put the brakes on developing oral aversion. And so we've got all of these different conditions that can sort of interlink with feeding. We need to make sure that if you've got a mild heart condition, that's not blamed for the appetite, but equally, if you've got a low appetite and a heart condition, that the portion of your appetite that that heart condition is impacting is dealt with in an attempt to improve appetite. So we're constantly juggling a sort of whole child approach in terms of our assessment of feeding. Now, we're worried about feeding because feeding difficulties have got multiple problems, not just with growth, but particularly with micronutrient deficiencies. Doctors are very quick to forget that iron deficiency causes symptoms long before it causes anemia, particularly glossitis, so inflammation of the tongue, pins and needles on the tongue. What does that do? It makes you not enjoy particular textures, particular flavors. And so measuring children's iron levels, making sure that iron is put back into the diet through iron supplementation can sometimes actually help the pickiness of food, as well as helping with other symptoms such as fatigue and restless legs. We have problems with vitamin A deficiency in the most extreme forms of oral aversion, where children will only eat chips, for example. I'm using that in the American term of chips. I'm not meaning fries. Weirdly, McDonald's fries actually contain more vitamin C than an apple. So it's quite difficult to become vitamin C deficient with a bad diet, but chips are particularly low in vitamin A. And vitamin D deficiency is incredibly common as well, particularly in the British climate, which is obviously a far lot darker and colder than it is here in temporarily sunny Florida. So we can end up in a vicious cycle of iron deficiency causing problems in the mouth, causing bad appetite, causing iron deficiency, causing problems in the mouth, causing bad diet. And so some of these vicious cycles are one of the things that we urge to treat, just in order that we can see what the actual problem is. Now, of course, there are lots of confounding factors when you're looking at children who don't eat very much. Here we've got a child who is falling off the centiles, but is this because of a development of a growth hormone deficiency or a growth hormone insufficiency? It's quite hard to tell. Now, what other metrics can we do? Well, we can check their IGF-1 levels, for example. That's their growth factors that are produced by growth hormone, but those also go down in malnutrition. So that's quite tricky to pick apart. We could look at their bone age, for example, their skeletal age. But this is a data set, again, from Mathel's study, that shows the bone age of our population of children with Noonan syndrome. And with or without growth hormone deficiency, with or without eating problems, they all have a lower than average bone age. We would expect bone age to be centered around the 0 there on the graph. That would be the standard normal. But the whole distribution is sort of slumped over to the left. And this is characteristic of Noonan syndrome, that we see a delayed bone age. So we can't use that either. So it's a really, really difficult field to unpick, and therefore parents are concerned about fussy eating. So we try to look at fussy eating and work out what causes it. And these are the sort of questions that we hear all the time. Why won't my child try new things? How can I show my child that foods are tasty? And this is why I want to talk to you about a magic lemon. This is a very special lemon that was designed by a neuroscientist at the University of Oxford called Charles Spence. Now, Charles Spence designed a lemon, for want of a better phrase, by reducing its acid content slightly, increasing its sugar content, and flavoring it with strawberry essence. So principally, he created a lemon that tasted of strawberries. And if you give this to 100 blindfolded people, they munch on it, they're very happy, and they tell you it tastes of strawberries. Give that lemon to 100 unblindfolded people, ask them to cut it up, and they haven't got a clue what it tastes like. They don't say it tastes of strawberries, they don't say it tastes like lemons. What they say is that it tastes of something that probably should be more lemony than it is. Now, what this shows is that expectation of what something is going to taste like actually alters your perception. They didn't go, my goodness, that tasted of strawberry. They couldn't identify the strawberryness of the lemon. And therefore, we can sort of apply this to a phobia model. Yeah? If you're afraid of dogs and you walk past a good dog completely unharmed, you're still afraid of dogs. Yeah? Having that one experience is not going to remove your phobia, okay? Because you've still got the expectation that it's dangerous. Similarly, if you're afraid of trying beef and you think that beef is going to be disgusting and you are forced to have it or coerced to try it, and you taste beef and it's sort of less disgusting than you thought it was, you're still going to be afraid of trying beef, okay? A single perception is not going to alter your expectation. And so what we need to do is we need to understand the psychological model as well as the medical model of how to treat feeding aversion in children. And so what we need to do is we need to look at why people are agitated. Why are parents concerned about this? This is a dot matrix display showing you how long you have to wait for a bus. It's the single thing that reduced complaints at London Transport more than anything else. People were complaining that they were waiting too long for a bus. As soon as they were told how long they were having to wait, they were using the opportunity to go to Starbucks and get a coffee. Yeah. Now, the reason why I bring that up is because sometimes the problem that people come to you with, I'm waiting too long for a bus, actually, if you reframe the problem and go, this is how long you have to wait for a bus, it stops becoming a problem. Yeah, it becomes an opportunity. And so some of the stuff that we have to do is look at feeding difficulties, reframe them, explain them, and as you were saying in your talk at the start, try to give people a roadmap of expectation, because expectation alters perception. And if parents have got an expectation of how things are going to go and what the narrative is going to be like, it becomes much easier to cope with because there's hope as well as expectation. And agitation alters perception. So as well as trying to treat the fact that parents are concerned about fussy eating, we also need to treat the fact that parents are concerned about fussy eating. So what are we doing at Great Ormond Street? Well, what we're doing is we're actually treating 3 different groups of people at the same time with our feeding service. We're obviously treating the child, but we're also taking a wider approach to treat the child's family and treat the child's healthcare professionals. They're part of the team, and if they don't fully understand the nature and the the roadmap for what's going on, then the child's not going to get the best treatment possible. So we've created an unusual form of clinic where patients can actually refer their doctors to us. We've sort of tipped the classic referral model on its head. And so where patients feel that their feeding disorders in particular are not fully understood by their local paediatrician, what we are starting to do is what we call a professionals referrals clinic. This is run by Danielle Lambert and Philippa Buckley in the Feeding and Eating Disorders Service at Great Ormond Street. And the principle of it is to take children with relatively rare diseases, in this case, RASopathies, whose paediatricians maybe only have 2 or 3 on their books and don't kind of see the patterns that we do, and get them in a room with us, with feeding psychologists, with psychiatrists, and with dieticians to talk through what they particularly recommend in terms of feeding programs, treating programs, and what might be able to be offered locally and what may need to be done elsewhere. And then the Feeding and Eating Disorders Service at Great Ormond Street or locally can look into these different issues. So we see a lot of ARFID and autism spectrum behaviors, obviously, also looking at nutritional management, but also looking at family pressures. Some of our South Asian and Orthodox Jewish families in particular have got very key cultural elements of what feeding and eating is. And so we work around, for example, trying to make sure that children who are feed resistant can still take part in Sabbaths and Passover celebrations. And we sort of work with family therapists to try and ensure that we can show that despite disability, there can be inclusivity as well. We obviously want to reduce the child's stress around food, but we also want to reduce the family's stress around food because mealtimes can be an absolute battleground. And the fact that a child is getting enough in to grow doesn't mean that a child's family isn't suffering or putting in an awful lot of unnecessary angst and agitation. And we will need to integrate plans with family, school, and local services to make sure, as we heard at the first talk, that school understands how feeding, etc., needs to go at school. Some children, for example, may need to snack during the day if they can't stand the smell of the school refectory or can't take in the quantity of food at lunchtime that they need, but need to snack through the day. That sometimes needs to be put into a special education plan. So the outcomes of the clinic, as we foresee it, are that we can expedite local child and adolescent mental health service referrals. We can involve family therapists to try and coordinate a family approach to reduce stress in the family home. Feeding and eating disorder services where needed for children with ARFID. But the bottom one of reassurance is actually the hardest one, because reassurance is often very dismissive. It's often saying this is not a problem, but actually reassurance is a process. Reassurance is a journey that you have to go on. And in order to understand how to reassure people, in order to understand what the typical markers of nutrition can be, in order to understand how to deal with fussiness, we need to go on a narrative journey with the families themselves. So that's a little sort of insight into what we're doing at Great Ormond Street. I don't apologise for the fact that it's a clinical rather than a research talk, but hopefully a magic lemon has introduced you all to why food aversion is quite more challenging to deal with than some people originally might think. Thank you very much for giving me the time. I'm looking forward to listening to you all for the rest of the conference.
Great. Thank you so much. Fascinating, and no apologies ever for the clinic, because it's the questions in the clinic that help us in the lab. So fabulous talk. We have time for a question.
Oh, that's easy.
Well, you're not off the hook. So with regards to the clinic that you've put together, do you see, speaking about research, and I mean, do you have partners in your area that you can kind of snag with regard to modeling or something like that for RASopathy?
At Great Ormond Street, we're heavily linked with University College London and the Institute of Child Health. In London. In fact, the Institute of Child Health pretty much is linked by a corridor to the hospital. And Mehul Dattani, who's one of the endocrinologists, is a senior researcher there, and Lee Hudson, who was also on the slide, is a researcher there and a general paediatrician. We're sort of starting our research journey now because the clinic's been going for 3.5 years, and it is in the nature of the science of genetics that it sort of started off as a pattern recognition. We think it's all about height and cardiology sort of situation. But really, the great thing about starting with the clinic and then moving into the research, rather than starting with the research and then moving into the clinic, is that you get to hear all of these powerful stories. And when you hear the same story 85 times, you kind of go, there's a pattern here. There's something I haven't been taught. There's something I haven't learnt. There's something I haven't read about. There's something I'm trying to read about but can't find. And I owe it to all of these people to try and do something about it. So we're trying to piece together from the clinic end what matters to families rather than what's out there already. And so we've really picked feeding disorders and leg pains as the two things that we think matter most to families but are under-described in the literature. Mattel's got a poster pretty much about leg pains, but we're starting off on that journey. And so we're looking at growth hormone resistant leg pains, growth hormone therapy in leg pains, different types of leg pain. With feeding disorders, we're working with some colleagues in Italy, Chiara Leone, who's not here, but I know that you know her, has started to try to pull us into her whirlpool of research, like a sort of, I don't know, a siren.
Well, you picked
Yeah.
two good topics, so
Thanks.
thank you so
No.
much.